Very good afternoon to all of you. So, on behalf of Department of Surgical Oncology, we extend warm welcome to this grand round. Uh, when we were discussing about what to talk about, essentially, this was the one topic where we thought that two changes have happened over last 2 decades, should I say, or maybe 1.5 decade. When we were training, esophageal cancer used to be number 4, number 5, somewhere in the GI cancer list. Stomach, gallbladder, etc., all being way ahead. It was kind of eye opener when the data from AIIMS registry came into 2020, and it's now the number 1 GI cancer. So whether we like it or not, we are going to see more of it, and more unless we are really having a nationalized screening program just like Japan and Korea, the situation is going to be the same. If the situation is going to be the same, the onus comes on the clinician side, then within that framework, what is to be improved in terms of the outcome. That's precisely we are going to talk about, and we will be discussing our data also, our experience over from 2012, when some protocol changes were made, and also the changing trend in the nature of the surgical approach. Dr. Sandeep will be talking about that. But before that, let me just introduce the speakers from various departments. It's a multimodality, multidisciplinary disease which requires a true multimodality approach as well as coordination of the treatment. So apart from Department of Surgical Oncology, we will have inputs from radiology, medical oncology, radiation oncology, anesthesia, and then finally, the house will be open for all the comments. So first of all, I'll request Dr. Naveen to start the discussion, and he will be talking about more about the clinical aspect as well as epidemiology. Dr. Naveen, please.
Thank you, sir. Good evening, all. So I'll be discussing about the incidence and prevalence epidemiology of the esophageal cancer. And we'll be talking about both squamous cell and adenocarcinoma, because there are two subtypes of esophageal carcinoma. First is squamous and second is adeno. So if we talk about the incidence of esophageal cancer in worldwide, so it is 11th most common cancer. And if we talk about the mortality, it is the 7th most common cause of mortality worldwide, so among all the cancers. So it is this incidence and the mortality is going up. So we have to be keep on the watch. And if we talk about the incidence of esophageal cancer, so which region has most common prevalence and incidence? So Asia has the most common prevalence and incidence of esophageal cancer, at approximately 74% among all the continents of world. So this is the heat map of the global data. So we can see here that the most common incidence and prevalence is seen in the Eastern Asia and the southern part of the Africa, and that is particularly in China, Japan, Korea, and to some extent to the India also, because now we are seeing the higher incidence of esophageal cancer in Indian population also. So if we talk about the incidence, there are two subtypes. One is squamous cell carcinoma and second is adenocarcinoma. And if we talk about the incidence of adenocarcinoma, that is more prevalent in the American countries, European countries, and squamous is more commonly in the Asian countries. But the incidence of adenocarcinoma is going high and is rapidly increasing. But the squamous cell carcinoma is still the most common cancer worldwide. So this is the Indian data which was published in 2022, and it has shown that the esophageal cancer is the 7th most common cancer worldwide. 5th most common cancer in India is the 5th most common cancer, And if you talk about the sexual differentiation, so male has the and in the male it is the third most common cancer, and in the female it is the seventh most common cancer. In both the populations, you combine both, so the incidence is almost, it's some fifth most common cancer, and and it is the most common GI cancer nowadays in Delhi, which we have seen in our hospital registry database. So this is the projection of the esophageal cancer worldwide. So we'll add up almost 3 lakh cases in the next between 2022 to 2045. So this is the cancer registry program, which we have shown that the most common cancer is the esophageal cancer. So this is especially worrisome for the Indian populations, because now the most common cancer which we are seeing in our OPD is still the esophageal cancer. So what are the risk factors for the esophageal cancer? So if we talk about the adenocarcinoma, the most common risk factors are the obesity, smoking, gastroesophageal reflux disease, whereas the common risk factors for the squamous cell carcinomas are tobacco chewing, alcohol, and tobacco smoking, poor socioeconomic status, and the dietary habits. These are the commonest causing agents for the squamous cell carcinoma. And almost 90% of the patients present with dysphagia, maybe grade 1, grade 2, grade 3, grade 4. And Indian population, the majority of the patients present with grade 3, grade 4 dysphagia. The other symptoms are vomiting, anorexia, weight loss. And the weight loss, if we talk about weight loss, the majority of the Indian populations have almost more than 10% of weight loss. So that is very significant, and that also impacts the outcomes of the patients. So as far as investigation is concerned, so all the patients routinely go for upper GI endoscopy and the biopsy, followed by the staging. The staging we usually do with the CT scan or the PET scan. Nowadays, the PET scan is recommended. So we are going almost all patients with PET scan, because PET scan will definitely define the extent of the treatment, as well as sometimes it helps for the radiation physicians to make their portal for the radiation. And second is the CCT abdomen. Sometimes it helps to the surgeons to assess the resectability. And third is the endoscopic ultrasound. But the problem with the endoscopic ultrasound in the Indian population is that 60 to 70% patients are non-negotiable growth. So that is why it is not feasible in the Indian populations. But for the staging in the early patients is helpful for the to define the T stage, whether it's a T1, T2, or T3. And all the patients usually go for PFT to assess the functional outcomes. So I request Dr. Mukesh for the radiology part.
Good afternoon. I'm Dr. Virun. I'll be discussing the spectrum of CT findings in carcinoma of esophagus. First, coming to anatomy of normal esophagus. Normally, esophagus is oval soft tissue density structure with intraluminal air, or if a contrast, if you have given oral positive contrast on table, and the wall thickness is thin, imperceptible, and measures less than 5 mm in thickness. Posteriorly to the esophagus, we have descending thoracic aorta and esophagus vein, and there is a triangular fat vat seen between the esophagus, aorta, and vertebral body. Now coming to CT findings, the carcinoma esophagus may present with wall thickening, which may be more than 5 mm, which may be circumferential or asymmetric, with luminal narrowing, with proximal dilatation and contrast holdup, or there may be intraluminal polypoidal mass, and there may be invasion of periesophageal tissues, which include fat, aorta, as the esophagus lacks serosa. There also can be regional roll spread into periesophageal nodes, subcarinal nodes, left gastric nodes, or celiac nodes. And lastly, there can be mets in non-regional nodes like supraclavicular and retroperitoneal nodes, and visceral mets in common sites include liver, lungs, bones, and adrenals. We'll show the representative images of each of the findings. Now, this is the case of 57-year female presenting with squamous cell carcinoma of mid and distal third of esophagus. Now, this is the axial CCT section below the level of carina. We can see there is circumferential thickening of the wall of esophagus, and centrally we have nasogastric tube within. And incidentally, this patient also had consolidation in right lower lobe with right pleural effusion. And in the lower sections, there is involvement of gastroesophageal junction also. So we can see in these coronally formatted images, there is long segment thickening involving mid and distal thoracic esophagus with involvement of G junction. Now next finding include invasion of periophageal tissues. As you can see, there is loss of triangular fat pad between esophagus, aorta and vertebra. So this is invasion of periophageal tissues, and also the contact of aorta is more than 90 degrees with the aorta, between esophagus and aorta. So these findings, tumor contact more than 90 degree, loss of triangular fat pad, and nodular protrusion into the airways makes the disease T4 disease, which is considered unresectable. Next finding is regional nodal spread. So it is relatively insensitive for nodal spread as it can miss small nodes, and we consider nodal involvement if the size of the node in short axis diameter is greater than 1 centimeter. So we have subcarinal node here, which is centrally necrotic also. This is greater than 1 centimeter. And next we have gastrohepatic ligament node. This is also more than 1 centimeter and centrally necrotic. And there can be mets in non-regional nodes like retroperitoneal nodes. Here we have paraortic nodes, and we also have visceral mets in liver. Here we can see hypoenhancing lesion in segment 2 of liver, which is liver mets. Thank you. Now next we have neoadjuvant treatment planning from Department of Medical Oncology.
Good afternoon, respected faculty and dear colleagues. So, more than neoadjuvant, I would advocate it as systemic therapy in CA esophagus. Let's see what are the importance. So, why systemic therapy? Of course, wherever there is a locally advanced and local disease of CA esophagus, surgery is the primary modality of treatment. But with surgery, over the years, like 5 years survival, 3 years survival, it's dropped to 30 to 15% with only surgery only modality. Excuse me. How do you move this? Okay, this one. So here is the OS curves. Here you can see any node positive disease. The overall survival just drops to 30 to 15%. So here, and in any upfront presentation, only 30 to 40% of patients can undergo the upfront surgery. So with surgical monotherapy, with 5-year overall survival, if any node positive disease drop to 13 to 15%, there comes the role of neoadjuvant and adjuvant chemoradiotherapy. So here, even with the best surgeries and with R0 resection or zero resection, microscopic negative margins, the PAT-CR correlates with the survival outcome with the mean absolute benefit of 33 to 36%, almost 1/3 absolute survival benefit for those who achieve PAT-CR. This is very important because these days we are moving from chemotherapy to the era of immunotherapy, where the newer trials like Metahon have shown the benefit of 36 to 40% of CR rates, where it has improved it will be improving the overall survival when the data is mature. So here we have two different subsets, that is squamous and that is adenocarcinoma. In the squamous cell carcinoma, there is a meta-analysis in 2018 which showed chemoradiotherapy has the better PAT-CR rate and R0 resection. The benefit was more in the squamous subpopulation. So neoadjuvant chemoradiotherapy is the standard of care with weekly paclitaxel and carboplatin, elaborated from the Dutch cross trial, which I will be telling. So that is the standard of the care across the world as well as in our institute as well. The other chemotherapy regimens are CDDP-5FU from the previous trials from the previous decade, and CDDP-vinorelbine from the Japanese trial, which is the standard across China and East Asia. So if not eligible for RT, we can give a patient chemotherapy, neoadjuvant chemotherapy followed by surgery. That is the MRC trial. The data is from the MRC trial. If not eligible for surgery, definitive chemoradiotherapy from the RTOG 8501 is the evidence for it. And if the patient, almost 25 to 30% of the squamous population, they undergo PAT-CR. I mean the radiological complete remission. When you do the CT scan or a PET scan, there will be no disease. So what to do with these type of subset of patients? They do ask us, should we undergo the morbid surgeries? But however, we don't know what is the definition of CR post neoadjuvant therapy. Whether recent data have shown that the newer modality like PET, the endoscopic ultrasound with the FNAC, and the MRI modalities with the ADC, with the diffusion coefficient, all these modalities may help the patient to forego surgery. However, the data is not matured and we don't know what is the outcome of it. Right now, observation followed by salvage surgery is the, if recurrence, we might not advocate it because we don't, the data is not yet mature. So there is no role of sequential chemoradiotherapy. The trial from NEJM in 1997 showed that we don't have any role of sequential chemoradiotherapy. It is a neoadjuvant chemoradiotherapy for all squamous cell carcinoma esophagus. So here you can see the landmark cross trial. The CA esophagus with any node positive or T2 with any node, or age less than 75 years, PS less than 2, and less than 10% body weight loss is the inclusion criteria. This I am stressing very important because wherever the patient of CA esophagus present to any of the allied departments, importance of nutrition should be stressed because less than 10% of the body weight loss is an independent predictor of mortality and poor surgical outcomes. We have various modalities like ultrasound guided NG insertion, percutaneous enterogastrostomy, and FG insertion. However, a percutaneous enterogastrostomy you should avoid when the gastric pull-up procedures are planned. So with the discussion in the multimodality MDT teams and other allied departments, very important is the nutrition. Both because they would have already lost, because of the tumor bleed, they'll have iron deficiency anemia, because of poor dentition and dysphagia, they'll be having very small meals. So we have a very good nutrition team at IRCH. So with consultation with them, small volume dense feed should be advised to these patients. So in this cross trial, they took these type of very strict inclusion criteria with 1:1 randomization with surgery alone versus weekly chemotherapy with radiotherapy. Radiotherapy details, I'm not going into details, which will be discussed further. The weekly chemo arm was paclitaxel 50 mg per meter square and carboplatin at AUC 2. So here you can see the curve. The overall survival at 5 years was 38% in the neoadjuvant CRT arm versus 25% in the surgery alone arm. So this is the benefit of the chemotherapy. And here you can see the benefit is more in the squamous cell carcinoma. In the squamous cell carcinoma subset. There is biological plausibility because we already read about the risk factors. These risk factors induce a lot of mutagens and lot of tumor mutation burden in this subset of squamous cell carcinoma. So these chemotherapy and neoadjuvant radiotherapy help these tumor to regress faster. So coming to the one more landmark trial, which is across practice in China and East Asia, that is the CA esophagus, any node positive or CT4 disease, 18 to 70 years. Karfanowski score of more than 90, equivalent to PS less than 2. No history of chemoradiotherapy or cancers. Again, 1:1 randomization, surgery alone, 2 cycles of chemo. Vinorelbine 25 mg per meter square, day 1, day 8, and CTDP 75, very difficult to administer with the logistic issues. We can divide it into 25 into 4 days. However, this we are not practicing because it had lot of, up to 85% had the what we say, the hematological toxicity, any grade of neutropenias. So it's very difficult with our logistic issues and emergency backups, patient presenting at very late stage with sepsis, difficult to practice giving this chemotherapy regimen. Here you can see it's almost the group which had CRT, the median survival is almost 100 versus 60. And here if you go for disease-free survival, it is 100 versus 40. So this is the benefit of neoadjuvant chemotherapy. So previously there was a convention that if you give neoadjuvant chemoradiotherapy, the patient, there will be a morbid surgery, post-op recovery would be difficult. But however, across 92% and 90%, both in each of the arm underwent successful surgeries. So there is no harm as such. Coming to adenocarcinoma esophagus subset, CRT has higher PAT-CR rate and R0 resection. Again, meta-analysis 2018, but however, subset population less beneficial in adenocarcinoma. Before going to the bimodality therapy, anything more than 5% in oncology, we are excited. So MRC is 0E2, the MRC2 trial, which showed there was absolute benefit of 5%. And UK MAGIC trial also showed there was benefit with the neoadjuvant chemotherapy. So here, when we developed over time, there was an idea that can we omit radiotherapy in this subpopulation, that is adenocarcinoma esophagus. I'll be coming to this data, that is neo-AGs in phase 3 ESOPEC, which is transformed into just only chemotherapy, neoadjuvant chemotherapy followed by surgery. So definitive CRT is is inferior in adenocarcinoma subset, that is from the JCO 2014. But however, patients who undergo surgery have better outcomes in esophageal adenocarcinoma. Unlike squamous cell CA esophagus, where definitive CRT is an option, but however, definitive CRT is not an option in adenocarcinoma esophagus. So the chemotherapy backbone is the standard FLOT, that is the 2-weekly regimen of FLOT with GCS of primary prophylaxis. If CRT is used, then cross is the regimen. However, there is from Prodigy trial, there is data for FOLFOX as well. So here is the landmark FLOT trial, AIO. There is a CA esophagus. Here, approximately 26% were the J junction tumors. Any T2N1, more than anything about more than T2N1 disease, age more than 18 years, no history of cancers, 1:1 randomization between 3 ECF, that is a perioperative, 3 before and 3 after surgery, or 4 cycles of FLOT, docetaxel 50, oxaliplatin 85 with leucovorin biomodulation of 200 and 5FU of 2600. So here you can see the difference in the overall survival. The FLOT arm has the better overall survival. And here also you can see the disease-free survival, the FLOT arm is doing better. So here we don't know which, but however, there were no head-to-head trial between just only chemotherapy versus definitive chemoradiotherapy. So phase 3 ESOPIC trial, which compared between the FLOT versus cross regimen, OS and PACR were better in that arm, and this is only abstract. We have the data. Phase 3 neoages. Here I am showing the curves. Here you can see perioperative chemotherapy versus trimodality group. There is no overall survival benefit. So this concluded that neoadjuvant therapy in adenocarcinoma esophagus is non-inferior to definitive CRT. Sorry. Toxicities were comparable. 31 to 32 in the both arms. Yes. No. It was marginally higher, but grade 3 were comparable. In grade 3 and 4 was comparable, manageable. Grade 1 and 2 were marginally non-statistical. So we always speak about the PACR because it always correlated the survival, better disease-free survival outcomes. So when there is no PACR, unfortunately, when we find disease post-op, there is nothing to worry. We have the better data. Adjuvant nivolumab for residual disease, 1 year of nivolumab. Immunotherapy, just in brief, immunotherapy is cancer is like an antigen, and there is always immunity in the body which fights against. So what happens in cancer? Cancer cells will express some ligands to block it. So we block this pathway, so enhancing the innate immunity and adaptive immunity to fight against the cancer. So here, adjuvant nivolumab with the patient assistance program, that is called Kiran, available in India for Indian citizens, approximately 8.5 to 10 lakh. If not affordable, 2 more cycles of chemotherapy, non-cross resistant, we might offer. The data is from JAMA. Coming to chemotherapy, NACT is always better than adjuvant. But however, when patient is operated outside, not the benefit of adjuvant, we do offer from JCOG 9907, which has the benefit of 1 year overall survival. If not received NACT, adjuvant chemotherapy has to be given. For high risk, we give chemoradiotherapy, that is any node positive and T3, T4 disease and margin. If chemoradiotherapy, if CRF is, the margins are positive, and if any nodal positive disease. See, otherwise, if the patient is not eligible for RT, or if for any logistic reasons RT is not advised, CT alone otherwise is also an option, but however, it improved only PFS, not OS. So coming to just in brief, the systemic therapy in advanced disease, almost 40 to 50% of the patient present in the advanced stages. We assess the HER2 status and PDL1 status and MMR. So these 3 are the basic things which we request the pathologist. If there is HER2 positive and CPS more, we offer trastuzumab along with the PDL1 inhibitors, the immunotherapy. If it is less, though there is a less benefit in squamous cell population, adeno, there is no benefit in the lower CPS and TPS scores. In squamous, whatever the score, there is benefit. However, the benefit is gradient. The best of the benefit is more than 10%. So CPS more than 10%, we offer immunotherapy along with the chemotherapy. With this, I conclude. And there was also very exciting data coming up with PACR increasing up to 40% with phase 2 data from DCSF in squamous cell carcinoma population, and the Matterhorn study where there is neoadjuvant durvalumab. However, these data are not yet mature, and 2024 we cannot advocate them. And this is the landscape of neoadjuvant and adjuvant chemotherapy in CA. Thank you. So the data for this is the phase 2 trials. In the monotherapy, we have Keynote 590 and Checkmate 648. And in phase 3 randomized trials, we have Keynote 859 and 649. All of them showed the overall survival benefit. And in second line also, we can, however, less than 50% of the patient are eligible for second line chemotherapy in our setup. The Attraction 3 and Rationale have promoted the monotherapy of immunotherapy agents, and TOGA trial has showed the overall survival benefit with the trastuzumab. Thank you.
Good evening, everybody. Role of radiation therapy in CA esophagus. Actually, it starts from the clinic and not later. And in the clinic, along with the other team members, the role starts in selecting the right patient, selecting the modality, the technique, and the close coordination between the various specialties. I can't take this opportunity, lightly to convey the matter that the radiation oncology referral should not come as and when during the course of treatment, but instead it should be a part of the treatment plan to execute at every step the way it should be. In the best of the technicalities and the sophisticated gadgets or the radiation oncology advancements that we have, a poorly selected patient is not going to give us a good outcome. Can I have the first slide, the tumor board? So here again, we emphasize the need for tumor board, not just for the sake of discussion, but just to emphasize how important it is to have a close coordination right at the outset and not during the treatment. And like I said, we have to look into the treatment, the radiation treatment planning staging and the staging at baseline in the clinic. There is a change of about more than 30%. More than 30% of cases of CA esophagus have moved on to the metastatic or to an advanced stage, which no longer makes them suitable for a radical treatment or a curative treatment. So they lose the importance of working hand in hand and understanding each other's strengths and limitations and respecting the timeline, because this disease has a very small window and each modality have a very specific window to act upon. And it doesn't take time for us to move from one stage to another, and thereby becoming a curative case turned to a palliative one. So with this, I'll ask my colleague Adila to take us through our role in the neoadjuvant setting, in the definitive setting. Adjuvant, of late, we don't do much. Most of the cases are planned. We see hardly a T1 with an upfront surgery and see the need for an adjuvant treatment later. Most of them are either in the neoadjuvant CT-RT or in the neoadjuvant CT, as the case may be, depending on the histology, or the definitive setting, depending on other factors like the performance status, the nutrition, so on and so forth. So Adila is going to take us through. Thank you so much.
Good afternoon. I'll be talking about the role of radiation in the management of CA esophagus. For cervical and upper thoracic esophagus, the treatment of choice is definitive CT-RT. For middle and lower thoracic esophagus, it's either a neoadjuvant chemoradiotherapy followed by surgery or perioperative chemo and surgery, especially in adenocarcinoma and lower thoracic esophagus. And for unresectable cases, definitive CT-RT. This is a protocol, radiation oncology protocol. For neoadjuvant CT-RT, we select patients with resectable primary CA esophagus greater than or equal to T2, especially but not limited to this squamous histology. RT protocol is 41.4 gray in 23 fractions over 4.5 weeks with concurrent paclitaxel and carboplatin according to the cross protocol. For definitive CT-RT, it's either cervical and upper thoracic esophageal primary or unresectable non-metastatic primary CA esophagus not involving great vessels and airway. The RT protocol is 50.4 gray in 28 fractions over 5.5 weeks. Adjuvant RT is offered to those patients who undergo upfront surgery without any neoadjuvant treatment if they have any evidence of R1 resection or lymph node positive disease. The dose is 45 to 50.4 gray in 25 to 28 fractions. The evidence for neoadjuvant treatment is from the CROSS trial, which was already discussed here, and it has shown that neoadjuvant CTRT is associated with a doubling of median overall survival over time and increased R0 resection rates. The survival benefit was even continued after 10 years of follow-up. It also showed that neoadjuvant CTRT was associated with less local, regional, and mixed relapses. However, isolated distant relapses were not reduced. This is the subset analysis. You can see the magnitude of change is higher in the squamous histology. For definitive CTRT, we have two randomized controlled trial which compared trimodality therapy with definitive CTRT and a Cochrane pooled analysis. It has shown that definitive CTRT has an equivalent overall survival compared to trimodality therapy with likely fewer treatment-related mortality, but local recurrences were higher with definitive CTRT. These trials addressed the role of dose escalation beyond 50 gray in definitive setting and failed to show any benefit. The role of adjuvant CTRT is actually extrapolated from the McDonald trial, which was mainly conducted in CA stomach, and it has shown that in cases with T3 or node positive disease, adjuvant CTRT is associated with a increased overall survival and relapse-free survival. Now coming to radiation planning. Radiation planning has evolved from the initial 2D conventional planning to the current state-of-the-art IMRT VMAT technique and even proton beam therapy as of now. However, currently VMAT planning technique is the current standard of care. The RT planning starts with the patient assessment and patient preparation, followed by CT simulation with IV and oral contrast. Motion management techniques like DABH and 4DCT is even used, especially in the lower esophageal and G junction tumors. It is followed by target volume and OR delineation in the planning CT scan. Then IMRT or VMAT plan is made. Once the plan is approved, the patient is taken for setup and CBCT is done for verification of the setup, which is then followed by a daily treatment under image guidelines. Before we even consider a patient for radiation therapy, these are a few of the many prerequisites that has to be fulfilled, including the performance status of the patient, medical comorbidities, nutritional support, and PFT and 2D echo respectively for pulmonary function and cardiac function. This is a 52-year-old male with no known comorbidities who was diagnosed as this carcinoma of the upper thoracic esophagus. The PET scan here is showing an FDG avid lesion involving the upper thoracic esophagus for a length of 3.3 centimeters. Here, this is the planning CT scan of the patient. The gross tumor volume was contoured after co-registering the planning CT with the PET CT and considering the endoscopic findings. This is the clinical target volume, which was contoured taking into account the microscopic spread of the disease in the primary and in the nodal setting. These are the organ at risk, which was contoured in the planning CT scan. Here you can see a beautifully sculpted dose painting of the planning target volume by sparing the organ at risk. This patient was planned with the VMAT technique with an anterior and posterior arcs. Now, supportive care is very important during radiation. Careful patient monitoring to manage acute toxicities and in order to avoid treatment interruptions is necessary. And weekly patient review and notation of vital signs, weight, and blood counts are important. Nasogastric feeding tubes or feeding jejunostomy should be considered if the caloric intake is less than 1,500. And adequate oral IV hydration should be given to the patient. To summarize, radiation therapy is an integral part of management of CA esophagus. For resectable squamous cell carcinoma, NACTRT should continue to be the standard of care. For resectable adenocarcinoma, NACTRT should be the standard of care, although perioperative float is an equally effective option with a higher toxicity profile. For cervical, upper thoracic, and unresectable CA esophagus, we can assess the patient for definitive radiotherapy. VMAT is the current standard of care, which is delivered under daily image guidance. Patient monitoring and supportive care is important to delivery. Thank you so much.
Good evening, everybody. So till now, we saw that patient of CA esophagus has undergone such a complicated algorithm of treatment options of chemotherapy and radiotherapy. So when such a patient is posted for surgery, we need a comprehensive anesthetic management plan, which starts from right from preoperative evaluation and ends at uh, post-operative outcome and till the discharge of the patient from the hospital. So in preoperative evaluation, it consists of a detailed history, physical examination. Apart from routine blood investigation, we order a PFT for baseline pulmonary function test. We have this machine of CPET. We do this test in certain high-risk patient for risk stratification for cardiopulmonary exercise test. In pre-op optimization, we optimize if the patient is having any concurrent medical comorbidities like hypertension, diabetes mellitus, or hypothyroid. We make sure that we refer the patient to dietitian because nutrition build-up in such patient is very important, such as high protein intake. Our primary goal is early recovery and discharge. So we follow all the components of ERAS protocol. In pulmonary rehab, if the patient is having any pulmonary infection, we treat it. Apart from that, we advise the patient for physiotherapy, deep breathing exercises, and incentive spirometry. And if the patient is a smoker, obviously we ask him to stop smoking. Now, since the surgeons require a optimal surgical field for esophagectomy, we do a lung isolation. The primary modality of lung isolation is double lumen tube. However, if the patient is having a difficult airway, it is difficult to put a double lumen tube. In that case, we go for the bronchial blockers. We have two bronchial blockers available at our institute. The first one is ARN blocker, and the second one is EZ blocker. Coming to fluid management, we keep a balance of hypovolemia and hypervolemia by following an individualized goal-directed fluid management plan. For extubation, we change the double lumen tube to single lumen tube or a supraglottic airway device. We optimize for the hemodynamic parameters. We reverse the neuromuscular blockade, and we make sure that we extubate the patient on OT table in 90% of the cases, and then we shift the patient to ICU. It is very important for such a patient to be pain-free for his better post-operative outcome. So we follow a multimodal analgesia, which consists of a systemic approach with opioids and NSAIDs, and a regional approach. The gold standard is thoracic epidemiology. In post-op management, these are the three important things which we keep in mind: adequate analgesia, early mobilization, and chest physiotherapy.
Thank you, Prateek. Good evening, everyone. I will be discussing about the surgical aspects of the esophagectomies. This is the latest AGCC 8th edition of TNM staging. It divides the esophagus according to the depth of the incision into T staging and according to the number of lymph node involvement as N1 and N2 and N3. So, in a tumor ward, as a surgeon, how we decide which patient needs which treatment. So, first of all, we have to see the histology of the tumor. If it is mainly it is squamous cell carcinoma or adenocarcinoma, other histologies include neuroendocrine carcinomas or leiomyosarcoma. First, if it is squamous cell carcinoma and the disease is early, then upfront surgery is advisable. If it is N+ disease or it is involving T2 or more than T2, then we have to seek opinion for neoadjuvant treatment in the tumor board. If it is adenocarcinoma, T1, T2, and N0 disease are candidates for upfront surgeries. Otherwise, T3 disease and N+ disease are a candidate for neoadjuvant treatment. After completion of neoadjuvant treatment, we have to look the disease biology, and if the disease is still operable, surgery is advisable. And if the disease is not operable, then supportive care or palliative chemotherapy or definitive radiotherapy, chemoradiotherapy is advisable according to the tumor board decision. So, in reassessment, we have to see whether the lesion is resectable. We have to assess the nodal burden, and we have to see whether the disease is metastatic or not. It can be done either by a good quality of PET CT scan or a CT scan. We have to repeat an upper GI endoscopy to see the upper and lower border of the disease and to see the negotiability of the disease. In our department, we have published a paper of response assessment by FDG PET on comparing two chemotherapy regimes. So, once we see that the patient is resectable, we plan the patient for esophagectomy. There are three procedures for esophagectomy. One is transhiatal, it is the oldest one.
Other is very common in contemporary world is transthoracic procedure, and the newest approach is cervical esophagectomy, where there is no incision in thorax. All the esophagus is mobilized by the cervical incision with the help of a surgical robot. Transthoracic esophagectomy are divided into either Ivor-Lewis, where the anastomosis is done in the thorax, McKeown's esophagectomy, where the anastomosis is done in the neck, and left thoracoabdominal is also a type of transthoracic esophagectomy, where the anastomosis is done in thorax, but the incision is different. So the basic principle of surgery is we have to get an adequate margin of at least 10 centimeter on both sides. However, if margin is not available on upper side, it can be done if it is available as 5 centimeter. These kind of margins are spared when we have a patient who had to undergo a salvage esophagectomy after definitive chemoradiotherapy. The minimum margin of 5 centimeter is required because the anastomosis, if we do on the cricopharyngeal junction, it will definitely it is going to cause problem, and it is the anastomosis is going to leak because the lower part of the anastomosis is involuntary and the upper part of anastomosis is voluntary. So tumor involving adjacent structures is considered inoperable, and at least minimum 15 lymph nodes should be harvested to stage the patient adequately. So we consider from the lower border of cricoid cartilage till clavicle, we consider this part of esophagus as cervical esophagus. From clavicle to the lower border of the carina, we consider as upper thoracic esophagus. From the lower border of carina to the inferior pulmonary vein, it is middle thoracic esophagus, and from IPV to the diaphragm, it is considered as lower thoracic esophagus, and below diaphragm till GJ, it is abdominal esophagus. So in transhiatal esophagectomy, a midline laparotomy is done, and surgeon bluntly opens the esophageal plane by opening the hiatus, and other incision is done in the cervical region, and other hand of surgeon goes from this side to bluntly mobilize the esophagus. Advantages of this kind of surgery includes it avoids thoracotomy, and it is of shorter duration, but it is a blunt procedure. There are less lymph node yields, and in certain patients, it is not considered as oncologically sound surgery. Transthoracic esophagectomy, first procedure is Ivor-Lewis surgery, where the midline laparotomy is done, and abdomen is opened, and stomach is mobilized. Later, the position of patient is changed to lateral position, and posterior lateral thoracotomy at 5th intercostal space is done. Esophagus is mobilized through this incision, and anastomosis is done in the thorax. McKeown's esophagectomy is also known as 3-incision esophagectomy, where we do a lateral thoracotomy, posterior lateral thoracotomy. We mobilize the esophagus through this incision, then we change the position to supine, and we do a midline laparotomy. After doing midline laparotomy, stomach is mobilized, conduit is formed, specimen is delivered, and we do an anastomosis in the neck through a 3rd incision. Left thoracoabdominal surgery is also known as Sweet's procedure. Here the patient is put into corkscrew position, and the upper midline incision is extended along the thorax as an anterolateral thoracotomy. This kind of surgery is used to do esophagectomy where the tumor is in the lower part of the esophagus. So earlier there was no difference between transthoracic and transhiatal surgery, and it depends on the surgeon's preference which surgery he or she wants to do. But it was the era when there was a not hue and cry of lymph node dissection. But when the concept of 3-field lymphodectomy is coming, transthoracic esophagectomy is becoming the surgery of choice for most of the high volume centers. So in earlier era, the randomized control trials was done to see is there any difference between transhiatal and McKeown's esophagectomy. Results of this randomized trial stated there is no survival difference among these two procedures. However, perioperative mortality was higher in transthoracic esophagectomy, and transhiatal esophagectomies are carrying higher incidence of anastomotic leak and RLN injuries. Similar type of results are seen in other meta-analysis also. So after removing the esophagus, we have to restore the continuity. and we form a conduit. Our first choice conduit is from stomach. If it is not available, or if it is necrosed because of previous surgery, we go for colonic. Either it can be right-sided colon or left-sided colon. If both are not available, we go for jejunal conduit. The route can be either subcutaneous or retrosternal or in the posterior mediastinum. When coming to lymph node dissection, it is divided into fields. First field is the lymph node along the branches of the celiac axis. Second field is mediastinum, and third field is cervical lymph node dissection. So for standard 2 field is the lymph node in the mediastinum and along the branches of celiac axis. Here the upper paratracheal lymph nodes are not removed. Lymph nodes along the recurrent laryngeal nerves are not removed. But when we do a 3-field lymph node dissection, along with this standard 2-field dissection, we remove the paratracheal lymph nodes along the bilateral recurrent laryngeal nerves, and lymph nodes along the cervical region below the omohyoid level. So this is the paper published from our department comparing the outcomes of the McEwen's and Ivor-Lewis esophagectomy. And we have noted that the anastomotic leak and vocal cord paralysis are more in McEwen's procedure, and there is no difference in OS and DFS. So now a concept of 3-field lymphadenectomy is coming up, and esophageal disease is the only disease among GI which carries 2 systems of nodal differentiation. According to the AJCC system, lymph node category is divided as N1, N2, and N3 based on the number of lymph nodes involved. N1 is called when the one or two lymph nodes is involved, N2 is 3 to 6 lymph nodes are involved, and N3 is more than 7 lymph nodes are involved. But 3-field lymphadenectomy is a Japanese concept. Here it doesn't depend on the number, but it depends upon the field. Suppose the lymph nodes along the abdomen is involved in one field only, it is N1. If mediastinum and abdominal lymph nodes are involved, these are N2. And if cervical lymph nodes are also involved, it is called as N3. So according to the latest NCCN guidelines, this states that the higher the number of lymph nodes you involve, it is better for the survival. So on the basis of that, at least 15 lymph nodes harvest is required to adequately stage the patient. So Japanese guidelines states that for thoracic esophageal carcinoma, extensive lymph node dissection in the form of 3-field lymph node dissection is required, and for esophagogastric junctional carcinoma, it is not clear. ESMO guidelines state that radical transthoracic esophagectomy with en bloc 2-field lymphadenectomy is the procedure of choice. So to conclude the summary of the lymph node dissection, 3-field lymphadenectomy provides adequate staging. It provides better locoregional control and improves survival. 3-field lymphadenectomy is recommended for thoracic esophageal carcinoma, squamous cell carcinoma, which is along with esophagectomy. In lower thoracic esophagus patient where upper mediastinal lymph node are involved clinically, 3-field lymphadenectomy is recommended. However, it carries a high morbidity rate and higher chances of recurrent laryngeal nerve injury. So, to do esophagectomy, there are 2 approaches. One is open and other is minimal invasive approach. It can use either robotic or laparoscopic plus VATS assisted. These are the name of the various approaches. So in open approaches, we give a large incision in 5th ICS and a midline laparotomy, big incision at the abdomen. In minimal invasive approach, we make 12 millimeter or 5 millimeter small port incision and a midline small 4-5 centimeter incision to retrieve the specimen. This is a small video from our department. This is the aorta, esophagus, this is the lung, azygous vein. So after doing resection, to do anastomosis, in Ivor-Lewis esophagectomy, we do a stapled end-to-side anastomosis, and for neck anastomosis, either we do a hand-sewn end to side or stapled side to side or diamond shaped anastomosis. So the advantages of minimal invasive esophagectomy is same for any GI surgery done by minimal invasive technique, but the chances of recurrent laryngeal nerve injury are more, and there is a higher learning curve for doing esophagectomy by MIS. Now I invite Dr. Amitabh to present the data from our department.
Thank you, sir. Good evening, esteemed audiences. I will be discussing about the IRCS data. This is our database for the offline storage of the data. This is an Excel format, and it has been maintained since 1994. So I'll be discussing about the demographic profiles of the patient, the surgical approach, perioperative outcome, and the long-term survival outcome. So from this database, we have picked up the patients operated between 2012 and 2023. That is 403 patients are included in this study, and among them, 59% is the male and 41% are females. The major symptoms of the patients presented to our clinic is the dysphagia, followed by the anorexia and vomiting. For the tumor characteristics, the 37% of patients are presented with a non-negotiable growth on the upper GI endoscopy, and extraesophageal involvement is noticed in the 28% of the cases. The regional nodes are detected in 25% of the cases. For the tumor location, most of the tumor located in the middle part of the esophagus, 57% of the cases, and followed by the lower part of the esophagus. And histology-wise, the most common histology is squamous cell carcinoma, that is 72% of the cases. After the discussion in the MDT, most of the patients underwent NSCT plus surgery in 57% of the cases, followed by NSCT RT and surgery in 17% of the cases. 14% patients underwent upfront surgery, and pre-op short course RT given in 20% of the cases. After neoadjuvant treatment, more than 70% of the patients has a favorable response, including the complete response in 9% of the patients and partial response in 63% of the cases. Most of the patients among the 403 included 403 patients. 78% of the patients underwent curative resection, and rest of the 22% patients are inoperable on exploration. And most of the patients are operated by open approach, that is 67%, and 33% underwent minimally invasive surgery. Although the share of the minimally invasive surgery has been increased in the last 5 years in our department, we can see here in 2029 there is a 36% cases which were underwent minimally invasive surgery, but in the rates has steadily increased in the last 5 years up to the 67%. So the most of the patients underwent McKeown esophageectomy, that is 59% of the cases, followed by AIIMS. And the anastomosis method used at the most of the patients underwent staple anastomosis, 65% of the cases, followed by Hansen. So in the final histopathology, 23% patient had complete response, and 77% has irreversible disease. And LVI and PNI positivity is 23% and 15% respectively. The margin positivity is only 2%. The proximal 1% has proximal margin positivity and 1% distal margin positivity among the 315 operated cases. That is less than 1%. Come to the final stage, most of the patients are belong to the stage 2, that is more than 50%, followed by the stage 3 and stage 1. Coming to the morbidity, the perioperative morbidity is around 10% in this series, and among them 5% has the 11 grade 3 complication. The perioperative mortality, as far as I remember, there is only 2% died in the perioperative period, that is less than 1%. And the most common complication is the anastomotic leak, that is in the 3.5%, which is comparable to the literature, which is around 5 to 10% in the literature, and which is less in our series. Hoarseness of voice is 1.4%, and as a whole, pulmonary complication is less than 5%. When we compare for the disease-free survival for the all curatively treated patient, then after a median follow-up of 29 months, there is a 3-year DFS rate is 65%. Sorry, and 5-year DFS it is 57%. The median has not reached yet. For OS, the 3-year and 5-year rate is 83% and 63% respectively. We compared the lower thoracic esophagus with the middle thoracic esophagus for the survival outcome. For DFS, there is no significant difference noted between the arm. The P value is 0.33, and the DFS 3-year DFS rate for lower esophagus is 64%, for middle esophagus 67%, and 5-year rate is for lower and middle 55 and 59% respectively. Coming to the OS, similar to the DFS, there is no significant difference noted between the lower and upper esophagus. Lower and middle esophagus. And for the 3-year survival rate for lower esophagus is 83%, and for middle it is also 83%. And 5-year survival rate is 59% and 61% respectively. The recurrence rate in this series is 30%, and most of them is the systemic recurrence, that is 21% for local, regional, and local. These are the sites of the abdominal nodal recurrence. The most common is the mediastinal nodal recurrence, followed by abdominal and cervical. And for the systemic site, most common site is the metastasis in the liver, followed by lung, bone, and the peritoneum. For the discussion of the ongoing studies and to conclude the session, I would like to invite Professor Sunil. Thank you.
Thank you, Amitabh. Anyone who picks up the literature 15 years from now and go for the survival studies, you will find that the best survival which was described was never more than 40%. 5-year overall survival I'm talking about, and the rider is that outside Japan. We have come a long way from there. Multiple factors, change of protocol, both neoadjuvant, adjuvant, and change of surgical techniques. Not only that, but most importantly, the perioperative care. What was converted into mortality is now remaining up to morbidity, if I can sum up in one line. So all these patients are surviving, and if you have done a good surgery, you have removed the disease, oncologically sound surgery, that is being paid a dividend in terms of a higher survival. But then if it's a esophageal cancer, it cannot be spared of any controversy. You heard that this is standard of care, this is standard of care. Absolutely, whatever is the standard of care, there is equal amount of controversy associated with that also. With that also, we have our own share, and we are also trying to figure it out within our circumstances, within our context, what is the best way to go forward. So this is the study which is comparing neoadjuvant chemotherapy versus chemoradiotherapy. We have our own logistical limitations, and this is addressed towards that as well. This will be comparing not only in terms of the short-term outcome, that is the perioperative features, but also the toxicity profile of NSCT and NCTRT, and also the arterial resection rate, because that is a surrogate marker for long-term survival as well. The second study is basically, if you have, like Sandeep talked about, the how to take the conduit, and then because leak itself is a very, very important complication, whether we can make a difference in terms of changing the route of the conduit, this is being seen in this study, and we are just waiting for the outcome. And if it works out, then this will be a remarkable change in terms of some improvement in the surgical technique per se. Because so far, all over the world, traditionally, we are using the mediastinal route as the first option. But if there is a good difference with this route, we may shift to that as well. Now, coming from the purely surgical technique, also this is another study which is comparing, like you saw the data and also the published strategies from the department itself, that if it's a lower esophageal cancer, do we really need to take out all the lymph nodes and also make the anastomosis high up, because the perioperative outcome of the McKeown's procedure is slightly or different compared to the Iverlase procedure. At least in the perioperative outcome, in terms of leak, in terms of the hospital stay, and in terms if the long-term survival is also equally good, then we can spare the patient of misery of recurrent laryngeal palsy as well through the two-field dissection and Iverlewis procedure. So just to conclude the entire proceeding, now it has become, the esophageal cancer has become the most common GI malignancy in our country. Although the surgery is the mainstay of treatment, but it's a truly multimodality management for cancer. You can name it. It will be the first one will be the esophageal cancer. Although multiple neoadjuvant protocols have been developed, but with their own riders, we need to develop our own. Let's just go for that, and we are working towards that. Regarding the minimal access esophagectomy, now it has become standard of care. Everybody has to be up to that, and it is something which is standard of care. And if even the poorest of the poor patient, which is coming to this hospital, is able to avail that facility without any question and with equal oncological safety as well. Although it is a complicated and multimodality management protocol, but then if everything falls in a place and in a coordinated manner, then you get the best result out of it. Otherwise, what we had, that nihilistic attitude 20 years back, it's going to continue. Thankfully, things have changed for the very good part of outcome, and then here we are. Thank you very much, because it's again, apart from the departments which have spoken here, we are really grateful, first of all, to the Department of Pathology, Nuclear Medicine, where we get the PET support, gastroenterology, pulmonary medicine. All our patients are going through at least one visit there. And certainly our nursing team, as well as the physiotherapist in the ICU and the ward, and also the dietitian. As you saw, why dietitian? Because everyone was referring to the cross trial, and one of the exclusion criteria for cross trial was that anyone who has lost more than 10% of body weight essentially is out of that trial. So far for that trial as far as concerned. Thank you very much. Now, if there are any comments, questions, we'll certainly welcome that. Try to answer that. Dr. Sharma sir, any comment or?
One more. You say that the collaboration between but I know for ideal the focus of no, not maybe technical. I'm not. There is no not much. Both treatments are not medical and radiotherapy and you're saying that they should be well planned.
Sir, I'll tell you. That's precisely the point I was trying to highlight, that it requires coordination.
No, basic, not
Mostly they receive, number one. And if they do not receive, the partly is because of the tolerance of the treatment itself, toxicity of the treatment. So yes, that's the reason I said that if we compare that with the rest of the world, probably the Indian patient is totally different. Here you will have most of the time, number one, middle third patient, number two, nutritionally debilitated patients. There you have to be very, very careful when we are planning for the so-called standard reference treatment protocol. It has to be tailor-made, otherwise they will be out of the treatment scenario altogether. So we are very careful, and the moment there is tolerance issue, again, ma'am, would like to comment?
No, I completely agree with what Dr. Sunil gave as one of the point why the neoadjuvant chemoradiation, which I think sir has seen that we are not doing as we should be doing, as good as we should be doing. But the problem is, we will agree all sitting in this room that we do have, that's why I said in my first slide that we need to respect each other's strengths and limitations as far as the logistics is concerned. We work in a very busy center. And I would say, even if we've not treated many patients in time, but I will look at it as the glass half full, not empty. We have treated many patients, in time and have a good result, as has been shared by the data by my colleague from surgical oncology. But what is important is that we need to make the plan at the outset so that we understand the waiting period for each one of us. We all know anyone who walks into AIIMS has a waiting period, whichever specialty they walk into, starting from the OPD to the execution of the treatment. However much a doctor can stretch oneself to see more patients in the OPD, that does not translate to the treatment, because certain areas like radiation oncology, or I would say surgical oncology, they would need a theater, we would need a machine. So let us respect the logistics and challenges that we face on a daily basis. So what is important is that we remain coordinated at our work right from day one, from the clinic till the completion of treatment, instead of thinking one can take the decision for the other. So here, each team member is a key player. That's what we need to, emphasize and respect. And as Dr. Sunil said, not all patients who walk into the OPD would be suitable for the treatment modality we've discussed here, because every treatment is customized. No patient is alike, and each plan is different. Plan for one patient cannot be repeated for the other. Depends on several factors, which is beyond the scope of a 1 hour discussion. But I'm so thankful that people are thinking about it seriously. So I can see some hope of improved facilities and improved care for the patient from each one of us. I'm sure patients walking into pathology also have a waiting period to get their reports reported. So that's the same for all cases, sir. Thank you so much.
Yeah, say it again, sir. Oh, some of them are more than 10 years. Essentially, they are. Yeah. What you saw actually is probably will be standing one of the best results in the world. More so because survival in this disease was never more than 40% till 15 years, not long back. Now we are crossing almost 60 plus, 65 plus, which is truly remarkable, to be honest. More so because we are able to give aggressive surgical treatment with the neoadjuvant completion protocol. Because once you have a good delivery of neoadjuvant treatment, most of the disease is downstage and to the tune of pathological CR, and these are the patients who are doing very well in the long term as well. So you have more number of patients who have received neoadjuvant, better pathological CR rate, and then that translates into longer term survival as well. Ma'am, your comment.
When we are working in
This is going to be, sir, because this is not a single modality treatment. So it has to be in a coordination. There is a timeline.
Dr. Anand, you were doing, you have done so many. And at that time, there was no
That's precisely I said that the scenario now is totally different.
no radiotherapy, no chemotherapy, there was only something.
No, it has.
The mortality I know about how this we have more than 600.
Yeah. So that is something remarkable, because otherwise all these patients who had some morbidity, many of them will be converted into mortality. We are pulling them back. I'm not saying that now the morbidity rate has remarkably gone down. It has gone down, no doubt about that. There is still a bit of that, but then that is not being converted into serious morbidity or to the extent of mortality because of the perioperative care.
want to say that we think that this patient maybe can they start no, I'm just saying
Before I conclude, thank our residents, Dr. Chinmay and Dr. Sivani, who are looking after the esophageal cancer database, and all the data was pulled out by them. Thank you very much. We are already 10 minutes past the due time, so we apologize for that, but then thank you.